Welcome and good evening, everybody. I am Laura Miles. I head up our U.S. sales team, and in conjunction with our medical affairs team, we are pleased to present to you tonight our webinar entitled Management of Generalized Anxiety Disorder with a focus on pharmacogenetics. As Dr. Dowd mentioned, this is a recorded webinar, and we will send you the link tomorrow to listen to it. And at the bottom of your screen, you should see a Q&A button. Feel free to put any questions you have in that dialogue, and our medical affairs team is on hand to answer your questions. We also anticipate, time permitting, to have a live Q&A at the culmination of our presentation. So let me tell you a little bit about Genomind and our company background. Next slide, please.
Surprise.
Okay, so one of our presenters is Dr. Tori Hoffman. As you can see, she is a PharmD. She is one of our medical science liaisons who is responsible for providing the clinical consultations with our customers. She received her PharmD from Albany College of Pharmacy and Sciences, and we are really delighted to have her on our medical affairs team. And in addition to Dr. Hoffman, we also have, speaking tonight, Dr. Russell Amato, who is a senior medical liaison, science liaison, and he received his PhD from LSU. Go Tigers. You probably have heard him on one of your clinical consults as well, and he obviously has some links here on some of his published articles and podcasts. So you are in terrific hands with our two presenters tonight. And maybe we have a quick little overview. Well, let me just quickly tell you a little bit about Genomind. So we were founded over a decade ago by world-renowned clinicians and scientists, and we are committed to compassionate care and psychiatric innovation. We pride ourselves not only on our scientific rigor and transparency, but also in destigmatizing mental health issues in conjunction with educating our clients on genetics. So this event is part of our Genomind 360 educational platform, where we deliver educational content, including webinars, articles, grand rounds, and CME. And we hope you enjoy it. And I will now turn it over to Dr. Hoffman to walk through the agenda.
Okay, great. Thanks for the introduction, Laura. So again, my name is Dr. Hoffman. Everyone can just call me Tori. And we're going to kick off our event tonight with starting off with what is generalized anxiety disorder. We're also going to go through the role of pharmacokinetics in GAD, the role of pharmacodynamics, and at that point, I'll turn it over to Dr. Russell Amato to talk about those pharmacodynamics and the role of genetics in startle response and HPA-axis dysfunction. We'll also go through a case together and then, time permitting, have a Q&A session. So let's start off with a discussion about anxiety disorders and generalized anxiety disorder. So it is estimated that 31.1% of adults in the United States experience an anxiety disorder at some time in their lives. And yet only 1 out of 3 people actually suffering receive treatment. All anxiety disorders have overlapping symptoms of fear coupled with worry. Incredible progress has been made in the neurobiological research of the brain that allows us to get a deeper understanding of the circuitry underlying these core symptoms of anxiety. For example, the symptoms of anxiety and fear have been associated with malfunctioning amygdala-centered circuits that involve serotonin, GABA, glutamate, norepinephrine, voltage-gated ion channels, and more. Anxiety disorders are the most prevalent psychiatric disorders and are associated with considerable degree of impairment, high healthcare utilization, and comorbidity. The focus of our discussion today is generalized anxiety disorder, which I will say from here on out as GAD, which affects an estimated 3.1% of the US population in a given year. So GAD is a chronic debilitating condition characterized by excessive and persistent worrying that interferes with many aspects of daily life. As shown on the NIMH website, so looking here in the blue chart, Figure 1 illustrates the prevalence of GAD among US adults ages 18 or older. So this was from 2001 to 2003. So let's fast forward to 2020. The number of people looking for help with anxiety and depression has skyrocketed. As shown in the yellow figure, Mental Health America revealed that the number of people screening with moderate to severe symptoms of anxiety continued to increase throughout 2020. And in September, 80% of the people who took an anxiety screen, which was over 50,000 people, scored for moderate to severe anxiety, with 48% scoring for symptoms of severe anxiety. So it's clear to see that GAD and the overall severity of anxiety continues to rise in the United States. So how are we actually doing when it comes to the treatment of this mental illness that affects so many individuals? The initial treatment of GAD can consist of medication, psychotherapy, or the combination of. Both approaches are efficacious, but it is unclear if combination therapy confers greater overall efficacy. The response to pharmacologic treatment for GAD is estimated to occur in 50 to 60% of patients, but remission in roughly 30 to 50%. So as I'm sure you're familiar, that the clinical presentation of GAD is extremely variable among patients, which absolutely contributes to the difficulty in recognizing and treating the disorder. It is not uncommon for patients with GAD to suffer from symptoms for months to years without seeking treatment or receiving treatment. It is hypothesized that a longer delay in recognition and treatment is a critical predictor of clinical outcomes. Further complicating successful treatment is the high rate of psychiatric comorbidity among patients with GAD. It has been estimated that 90% of patients with GAD also have at least one comorbid psychiatric diagnosis, most commonly major depressive disorder. As shown in the visual here, there are many drug-specific and patient-specific factors that complicate the pharmacologic treatment of GAD. But what if we could get a deeper look into some of these factors? It is important to consider that one of the factors that may influence treatment response is pharmacogenetics. So pharmacogenetics or pharmacogenomics is a field of research that analyzes how individuals' genes can affect how he or she responds to medication. As we were developing Genomind Professional PGX, we wanted to really drive home a few golden rules that are essential to understanding pharmacogenetics. So you're going to see those three main ones on the screen here. We have condensed these rules to number one, PGX is probabilistic and not deterministic. It cannot identify the perfect drug for a patient or eliminate every risk factor. Like all fields of medicine, it provides estimates of risk or response. PGX is only one piece of the clinical puzzle. It is meant to supplement good clinical judgment and patient evaluation and should never be the sole source of medication selection or dosing. And last but not least, although we do have genes associated with improved response to some medications, PGX still does a better job at assessing safety and tolerability to certain medications. The field is rapidly growing and new guidelines are routinely being published. So let's start off today with the role of pharmacokinetics in GAD. The term pharmacokinetics has historically been defined by the phrase, what the body does to the drug. In greater detail, the science of pharmacokinetics describes a drug's journey throughout the body and focuses on the absorption, distribution, metabolism, and excretion of drugs. One of the major components of pharmacokinetics is drug metabolism, which leads to the biotransformation of drugs within the body. Phase one metabolism typically leads to the production of polar, water-soluble metabolites. The cytochrome P450 or CYP450 enzymes are largely responsible for phase one metabolism. In fact, 70 to 80% of medications are metabolized by the CYP450s. So you're probably familiar with these at least a little bit. Phase two metabolism leads to the formation of larger water-soluble inactive compounds typically that are more easily excreted. In the first part of my talk today, we're going to go through phase one metabolism and the CYP450 gene variants that can play a role. but we will also discuss phase 2 metabolism in more detail later when we talk about the benzodiazepines. So looking at our visual on the right-hand side are metabolic effects on medication, blood levels. You will find medication concentration on the y-axis, time on the x-axis, and ultimately concentration over time curves for different rates of metabolism. The area under these curves represents that total exposure, accounting for peak concentration and the rate of degradation. So patients are typically reported as extensive or normal metabolizers, which we abbreviate as EM, intermediate, poor, rapid, or ultra-rapid metabolizers. So in that fast metabolizer category, those rapid and ultra-rapid, as you can imagine, when you're taking a specific medication, you're breaking these down much quicker than we would expect you to. Can be at a risk of reduced blood levels and may require a higher dose to achieve therapeutic efficacy. Now, on the other side of normal, the slower metabolizers, intermediate and poor metabolizers, they're at a risk for slower metabolism, so increased levels, and may require a lower dose and may benefit from that to reduce the risk for side effects. So several psychotropic medications have specific guidance regarding the clinical effects of these variants, including many of the treatments for GAD. So before we really dive into the pharmacokinetics of these treatments, let's briefly review the pharmacotherapy of GAD. So in summary, before we really get into it, secondary to the proposed neurobiologic basis for GAD, which we will touch on a little bit more later, drug therapies with evidence of clinical utility tend to target serotonin, norepinephrine, GABA, or combinations thereof. Shown here is a visual adapted from the 2016 Psychopharmacology Algorithm Project at the Harvard South Shore Program, which I will abbreviate PAPHSS on the slides here. In this algorithm, the evidence for the effectiveness and safety of these and other possible options are evaluated and sequenced in accordance with their potential value in particular contexts. At each decision point, which are referred to as nodes 1 through 5, you can see they also have letters on here as well, different options are available for consideration, enabling prescribers to select what seems best and most acceptable to the patient in each particular clinical situation. So, having confirmed the diagnosis of GAD, and considered the comorbidity and related issues explained in Node 2 and 2A, the authors of the algorithm found that the evidence still supports SSRIs as first-line medications for uncomplicated cases of GAD based on their safety and tolerability. In GAD, it is important to recognize that some patients require small initial daily doses to minimize experiencing the jitteriness and activation. So let's take a closer look at the SSRIs with a focus on those metabolic pathways we just talked about. So 2 SSRIs are FDA approved for use in GAD, escitalopram and paroxetine, which is why I included that little star icon next to them. The selection of a specific SSRI can be customized to an individual patient based on the drug's side effect profile and drug-drug interactions, but they should be equally evaluated for the potential pharmacokinetic gene-drug interactions, which you'll find in this column here. So you may or may not already know that the FDA has a specific maximum dose for citalopram as 20 milligrams in known 2C19 poor metabolizers. But did you know that there are also specific pharmacogenetic guidelines available for more than just the poor metabolizers and more than just citalopram? Actually, with the guidelines that I'm referring to, which we'll dive into shortly, as you can see in this column here, half of the SSRIs are major substrates of 2C19, while the other half are major substrates of CYP2D6. So, as we discussed earlier, variants in these genes are typically reported as normal, intermediate, poor, rapid, ultra-rapid. So just how common are these variants? So I've included here on the right-hand side an estimate of allele frequency that comes from CPIC. So CPIC is the Clinical Pharmacogenetics Implementation Consortium, which consists of a group of researchers that specialize in pharmacogenetic research from major institutions across the US. They have produced peer-reviewed guidelines related to many mental health treatments that we will discuss shortly. CPIC has also put forth standard definitions for the CYP450 genotypes and associated phenotypes. The stacked bar graphs here the stacked bar graphs shown were adapted from the 2016 TCA guidelines to provide a visual representation of CYP2D6 and 2C19 allele frequencies in the general population. It is important to recognize, however, that the approximate frequencies of these variations differ across ethnic populations and that they are often updated as we get more data. So let's take a look at these CPIC guidelines that I referenced. So 2C19 and 2D6 are two main players here, although we will touch on some of these other pharmacokinetic gene variants as well. So here I've included a little screenshot from the CPIC guidelines, which you can always look up. They're completely accessible. And they have specific dosing recommendations for 2C19 and SSRIs. So as we saw on that last page, citalopram and escitalopram and sertraline are all metabolized through 2C19. But when you look at these specific phenotypes, CPIC offers recommendations for each one of these. So for example, if you have a patient who falls in that faster than normal phenotype, so that rapid and ultra rapid 2C19 metabolism, they have faster than normally expected metabolism and potentially lower plasma concentrations, which according to CPIC's evaluation will increase the probability of pharmacotherapy failure. So their recommendations when you have a 2C19 ultra-rapid metabolizer are to consider an alternative drug, not predominantly metabolized through this pathway. So as we're looking at these SSRIs and we're looking at these guidelines, if I went through every single one of these, I would never give Dr. Amato a time to talk. I'm just going to highlight that one as an example, but I encourage you to look at CPIC, and from some of our other resources, you'll definitely learn more about this shortly. But ultimately, you can see how pharmacogenetics and looking with the treatments for GAD can really help us look at how to optimize our patient's current therapy and also look back on previous trials. If your patient had failed 2 SSRIs, but the SSRIs that they had failed were something along the lines of sertraline or escitalopram, that perhaps it's not purely an SSRI issue, but it may be a metabolism issue. It may be a consequence. They may fall in that category of people that have a very fast metabolism of one of these pathways. Now, it's also important to look at CYP2D6 with those other SSRIs. So on our next slide here, just quickly changed, we'll see some of the guidelines for paroxetine and fluvoxamine. So I'm just going to keep going, but I would be happy to come back to this if there's more time at the end. So returning back to our algorithm slide, one of the things I want to touch on before we move forward to has your patient had an adequate trial of SSRI? Yes, no, or yes and a partial response. One of the things I really want to emphasize when we're looking and talking about GAD is that the response time for antidepressants is generally anywhere from 4 to 12 weeks. Initial pharmacotherapy with an SSRI has shown to not lead to remission in up to 67% of patients will not achieve remission on SSRIs in GAD. As we discussed in the beginning of the presentation, there are many drug-specific and patient-specific factors to consider, but I hope that our discussion so far of CYP2C19 and 2D6 has shed some light on the potential influence that pharmacokinetic gene variants may have on SSRI treatment history, current medication, or maybe retrialing some. So again, like we talked about, there may be a consequence of these mechanisms of these drugs, as well as the therapeutic levels, whether they be super or subtherapeutic. So looking at this algorithm here, again, I want to emphasize that that first arm here, has this patient had an adequate trial of an SSRI? So the guidelines can kind of give you a couple different options here. So if your patient has had an adequate trial, but did not have a response, they recommend that you consider trying a second SSRI or duloxetine. So we will talk about those. If your patient has had an adequate trial and has a partial response, the algorithms suggest that you could consider augmentation with hydroxyzine, pregabalin, or benzodiazepine. And if your patient had not had an adequate trial of an SSRI, as you might imagine, you may want to try an SSRI. You could consider duloxetine, but some less favored but possible options within this arm of treatment include buspirone, hydroxyzine, pregabalin, and bupropion. So let's take a look at the pharmacokinetic parameters of each of these. So here I've included the SNRIs, the two that have FDA-approved indications for generalized anxiety disorder, and these alternative and/or augmentation options that fall within the guidelines here. So a couple of the things that I want to point out is that with duloxetine, that it is also subject to 2d6 genetic variability, as well as drug-drug interactions. One of the other interesting things about duloxetine is its metabolism through CYP1A2, which is sensitive to induction. Some people have genetic variations that can amplify that sensitivity to induction to things like drug interactions or environmental factors. Things like smoking, for example, can induce this pathway. So again, here's another piece of this puzzle that your genetic variability could also influence duloxetine and venlafaxine, which, as you can see here, has quite a few different pharmacokinetic pathways that are involved. And I do want to say that as of right now, there are not CPIC guidelines available for the SNRIs, but we do hope that that will be on their to-do list. I'm sure they're very busy, as we do believe that an upcoming review of Wellbutrin and the second generation antipsychotics could be anticipated in the near future. So with these two SNRIs, again, there's definitely drug-specific and patient-specific factors, but these pharmacokinetic genetic variations, as well as the susceptibility of these drugs to drug-drug, gene-drug, and even environment interactions might be another piece of that puzzle that pharmacogenetics can help shed some light on. Now, if we're looking at some of these alternative options and augmentations, we will talk about the benzos a little bit deeper on that next slide. But if you're looking at buspirone, which again also has an FDA-approved indication for GAD, it goes through 3A, 4, and 5. And I'm sure many people can recognize that this pathway is very common, in fact, one of the most common. Genetic variability in this differs vastly based on ethnicity. So it is very important to consider the pharmacogenetics when we're looking at these drugs that are substrates of 3A, 4, and 5, and of course, the potential for drug-drug interactions. And I keep bringing that up, and you'll see why shortly. Hydroxyzine, again, something that can be useful as an alternative and augmentation, but it does contribute minor 2d6 inhibition. So as you can see here, there's multiple pathways, multiple drug interactions to consider, so many new things to see all at once. But I'm going to show you how Genomind can really be your partner in making a lot of this much easier to all take in. But it's really important to consider, again, that these gene-drug, drug-drug, and environment interactions, pharmacogenetics can really shed light on them, but it can help us understand how to really individualize treatment to our specific patient. So I said we'd go a little bit deeper on the benzos. I don't want to scare anybody with the visual I included here, but I want to just take a moment to kind of talk about the benzos in general and then some of these pharmacokinetics. So the benzodiazepines in GAD, they are effective in the acute treatment of GAD, and they do often provide very rapid relief of anxiety symptoms. They can be useful for acute anxiety and to help mitigate some of those potential antidepressant-induced anxiety in the beginning. But the anticipated duration of therapy should be short-term. The benzodiazepines are recommended as augmentation or as an alternative treatment to be chosen after typically intolerance has been established with antidepressants. But considering that nearly 50% of patients with GAD have comorbid major depressive disorder, it's really important to recognize that the benzos are not necessarily effective in treating those depressive symptoms. So for the pharmacogenetics and the implications of genetic variability on these agents, a lot of these studies have focused on the metabolizing enzymes of the benzos. So these principal pathways that the benzodiazepines go through, as you can see on the slide, involve both phase 1 and phase 2. As I mentioned earlier, phase 2 metabolism you might not be as familiar with as you are with the CYP450s, but it leads to the formation of larger water-soluble and inactive compounds that are more easily excreted. UGT plays an important role in phase 2 metabolism, and mutations in this gene can actually produce changes in drug exposure. The specific enzymes involved in benzodiazepine metabolism vary, but most are metabolized by 3A4 and 5, 2C19, or UGT. Or they can be incredibly complicated, like diazepam, and have multiple active metabolites that involve each of these enzymes I just mentioned. So there's a lot going on here, and it is important to recognize that UGT2B15, being an intermediate metabolizer, is actually fairly common. Approximately 1 out of 4 people of European ancestry are intermediate metabolizers of UGT2B15, which is why we include it in our panel. So this variant can result in increased serum levels of some benzodiazepines. Both in vitro and in vivo studies have observed an impact of this polymorphism on oxazepam and lorazepam drug exposure. So looking at these pathways, that might make some sense because these are going through this pathway in a very large amount. They are not as affected by the phase 1 enzymes. So as oxazepam is an active metabolite of several other benzodiazepines, when you look at things like this, the drug exposure of these compounds may be affected as well. So that's why I included these major active metabolite pathways, just to bring some light to that. So when we're looking at our benzodiazepines, many people will say that an advantage of lorazepam and oxazepam is having fewer drug interactions than others. But while they may be less likely to be influenced by 3A4 and 5, these drug-drug interactions can also involve UGT. So it is very important to recognize that UGT can be inhibited, things like cannabidiol or levothyroxine, fluconazole, but also can be induced by things like carbamazepine or phenytoin. So I went through a lot of information there, and I hope no one was taking notes because the drug interactions, I'm going to show you why I brought all that up, how I know 2D6 does this and that. So as we go through these guidelines, I hope it has kind of become a little obvious why I went through each of these and how pharmacogenetics can really help you take a look at these guidelines and individualize your treatments to your patient. And it is extremely important to recognize that both the pharmacokinetic gene influence on these agents, as well as the susceptibility and consideration to drug interactions and environmental factors. But like I've mentioned, I'm finally going to show you, the good news is you have access to all of this information in one place. So for those of you that might not be familiar, we have GenMed Pro, which used to be called GDIG, and it's our state-of-the-art software that was designed to really help you look at this report in an interactive way. So it can help you check those drug-drug, gene-drug, and environment interactions all in one place, and you have access to this tool for every patient you order a test on. So if you're interested in more information about GenMed Pro, we've actually done talks specifically on it, which you can access on our Genomind 360 platform. So I thank you all for listening to me for those last several minutes. I'm going to hand things over to Dr. Amato.
Oh, thank you, Dr. Hoffman. That was great. Now it's my turn to be nervous presenting publicly. So we're going to pick up where she left off in the role of pharmacodynamics in GAD. Unfortunately, there are a few more limitations. Let me go ahead and expand this to full view mode. There are a few limitations when it comes to pharmacodynamics. Unfortunately, most of the research with these pharmacodynamic gene variants have been done in major depressive disorder. However, there may be some applicability. There may be some preliminary data that indicates that these same genetic mutations that affect treatment response to depression may also affect treatment response to anxiety, and we'll go over that during my section. But let's start off by talking about some of those gene variants that can impact SSRI response, since, as Dr. Hoffman mentioned, this is your starting point in your algorithm, right? Your Harvard South Shore algorithm. And what everybody's seeing here is a visual of the serotonin transporter. As you all know, right, the serotonin's released into the synapse. these reuptake pumps will take it back into the back into the presynaptic terminal to kind of clear that synapse of that serotonin. When you add an SSRI, you're going to get essentially decreased reuptake, right? More of that serotonin is going to be present within that synapse, and a mutation in your SLC6A4, like in this case, the short mutation, that can actually end up producing fewer serotonin transporters overall. You end up blocking an even greater amount of these things, right? Because there's so few left. And you'll actually get a flooding of these serotonin transporters. What is that? Or a flooding of the synapse, rather, with serotonin. So what does this do, right? What's the physiological consequence of having fewer serotonin transporters, having increased synaptic activity of serotonin? Well, unfortunately, it tends to lead to adverse events, poor response, at least when it comes to treating symptoms of depression, right? And so what you're looking at here on my screen is, there are 3 different genotypes. The first, LALA, is one that's typically more responsive to the SSRIs. They typically have lower side effect rates. Whereas the more mutations you have, a single S allele or one of these LGs, which produces about the same response, one of these risk alleles, well, you're going to have about a 50% increase in side effect rates with that SSRI medication. If you have 2 of those mutations, you'll not only get a reduction in response rate, remission rate, you'll also see, again, that same increase in adverse event rate that you saw with the single mutation. And we know we can apply that data, right? We know we can take that data and say, okay, well, these patients are more likely to have side effects, whether we're treating for depression or we're treating for anxiety, especially since in a lot of cases, right, anxiety requires higher doses. We can see how those results may generalize. But unfortunately, we don't know if those same results are going to apply to the response rate, to that efficacy, because, well, unfortunately, that was not the primary outcome of 95% of those studies. The only good news here, and I believe Tori mentioned this a little bit earlier, is that nearly 50% of patients with generalized anxiety disorder have comorbid MDD, right? So we may not need complete generalizability because these things, these diagnoses often co-occur. In fact, what Dr. Hoffman may not have mentioned was that the only thing that's more comorbid with MDD is other anxiety disorders like social phobia, panic, PTSD. And so we're going to talk a little bit about some of these things, right? Just so you guys are aware, there are a couple of pharmacogenetic gene variants on the professional PGX test that have been evaluated in GAD. It is fairly preliminary, but both of these receptors affect serotonin activation, right? Serotonergic neurotransmission. The first we just discussed, the SLC6A4. The second is the HTR2A gene, which is just a postsynaptic serotonin receptor, which responds to the serotonin, right? Activates that postsynaptic neuron. And one of the studies that looked at this response, specifically to generalized anxiety disorder, was a study by a guy named Falk Lohoff, right? He was at the University of Pennsylvania. Now I believe he works for the NIH. And what he found in his study was that, and the onus, right, the whole reason he decided to run this study, and you can read this in the introduction to this paper, he had the same issue we have, right? He saw all these studies in depression. He said, there's all this great pharmacogenomic data at treating depression. Does any of this stuff apply to GAD? And so he looked at it. And what he did find was that, at least in this small population, right, it started out originally as 156 patients. Unfortunately, due to the low frequency of the AA genotype in African Americans, they limited the overall analysis to about 112 of those of Caucasian ancestry. But what they found in this study was that patients carrying specific genotypes, in this case, the HTR2A G allele, it didn't matter if you were homozygous, GG, or if you were heterozygous, GA, those patients were much more likely to respond as assessed by that Hamilton A, right? The SLC6A4 also showed a better response, but only for patients carrying the LA genotype. And in case you guys are wondering why this result is a little odd, the drug they used was Venlafaxine, right? we typically think about the SLC6A4 affecting SSRI response, but in this case, there was actually a better response to Venlafaxine in treating generalized anxiety disorder. And so again, as you might imagine, the risk genotypes, right? SLC6A4 SS, HTR2A AA, those genotypes were less likely to respond, and they may struggle more with those primary antidepressants. Hopefully that was clear to everybody. One other gene variant that seems to affect portions of anxiety. Again, this isn't specifically generalized anxiety disorder, but it does tend to be fairly comorbid with generalized anxiety disorder. This was a study by Barbara Pitts. She looked at nearly 1,900 veterans, and she assessed these patients, not just the patients that were highly exposed to trauma, right, but all of them. She genotyped them, and she found that patients carrying the BDNF metallele were more likely to have greater symptom severity. In fact, it was incredibly robust and much more pronounced in those 605 patients who officially met the criterion of highly trauma exposed. And what we saw that in addition to this gene mutation possibly predisposing patients to increased levels of anxiety, it was also interesting to see that once these patients were exercising, they also seemed to get 2 to 3 times more benefit from that exercise. In this particular study, the exercise that they were looking at were sports, weightlifting, these types of things, and it was the median number of days to get this marked improvement, this robust improvement. It was about 3 days a week. And so, but that's the take-home message here, right? Is that if you're looking to treat some symptoms of your patient's anxiety, again, this may not apply to all symptoms of generalized anxiety disorder, that there may be some therapies like exercise that work better in one set of patients and, well, not quite as well in others, right? We still see a decrease in overall anxiety levels, PTSD symptom severity in this case, even for the vals, but the change is not nearly as drastic. Now, moving on, we're going to talk about the role of genetics in HPA-axis dysfunction and startle response. Why are we talking about this? Because there's been a lot of interest generated recently, right? You can see both the papers that I've listed up here were both published within the last 5 or 6 months. And they're essentially looking for a link between genetic polymorphisms, neural circuitry, and behavioral outputs. It's called an endophenotype, right? You can see they use that term here in the Julia Tomasi study. And the reason we're interested in this is because, well, if we don't have much data on drug response, can we at least identify who may be more prone to developing greater symptom severity, right? Can we identify people who may have more HPA-axis dysfunction? And so that's what we're going to go into now. I'll also mention that even Stephen Stahl mentions this in his Essential Psychopharmacology. It's in chapter 9, if you guys are curious. He talks a little bit about COMT. And so it's definitely a topic of interest. And what you'll notice is that, well, there are multiple genes on the professional PGX panel that look at this HPA-axis dysfunction, right? In this particular case, you're looking at COMT, SLC6A4, and BDNF. And what you'll notice is, and this is what I always like to say on consults, genes don't give you anxiety, right? They're not diagnostic. You can see that at baseline, before any of these stress tasks have occurred, for the most part, those genotypes have identical cortisol release. It's only after that public speaking engagement in the case of the COMT, right? A multiple serial subtraction task in the case of the SLC6A4, and submerging your hand in ice cold water in the case of BDNF, that these patients began to experience an increased fight or flight, right? An increased hypothalamic pituitary adrenal axis release of cortisol. It was interesting that BDNF actually saw a rise in cortisol just by being told that they were going to submerge their hand in that cold water. It's what the authors called an anticipatory stress response, and what Dr. Hoffman jokingly refers to as you can't spell anticipatory anxiety without Tori. What they found is that these patients just seem to be a little bit more susceptible to having this response. And when you looked at studies outside of these, right, this Armbruster, this Gottlieb, this Colzado study, they've actually found increased risk for things like PTSD, things like panic disorder, and even increased symptom severity in the context of childhood trauma, right? The more trauma you have and the more genetic risk you have, the greater that symptom severity is. And so there's been a lot of interest. And again, you know, while this talk is mostly geared around generalized anxiety disorder, panic, PTSD, these are commonly social phobias. They're very, very highly comorbid with that GAD. And so if you're thinking about suppressing your patient's sympathetic nervous system response, right, you're thinking of a beta blocker or something of that nature, and they do have this, what's called anticipatory or potentiated, right, startle, that may be a decent option moving forward for your patient. We don't have much drug data to support that because, again, right, this is based on physiology, it's based on mechanism. But we do want you to be aware that this association exists, and it may be something you want to think about when treating your patient. We also have a couple of other gene variants that seem to affect that fight or flight response, right? Specifically in this study with the calcium channel, the sodium channel. These two have been associated with increases in affective startle. They originally took 435 healthy Army conscripts from Crete. They played a 115 decibel white noise right behind their ear. That's about the level of a rock concert. So I want you guys thinking Guns N' Roses, right? Not so much Counting Crows. And their baseline startle was about 20 to 40% higher when you carried a single ANK3T allele or two A alleles at the calcium channel. Right? And one wasn't enough. Having one mutation at that calcium channel did not show a significantly different change in startle response, but having two of those A alleles did. And so again, we're just trying to identify those genetic variants that may increase our patients' susceptibility to anxiety. And what was really interesting is they did see increased anxiety measures and increased symptom severity in patients carrying these alleles. Why does it occur? Well, there have been several fMRI studies. I'm sure you guys are familiar with this, but if you're not, they usually use this bold fMRI, which stands for blood oxygenated, right? Now I'm going to blank on the LD, but essentially they're looking at blood oxygen of the, wow, now I'm losing it, of the brain tissue, right? In different parts of, well, emotional regulation centers, like the prefrontal cortex, your fear center, like the amygdala. These two brain regions, I don't think you guys need to focus on as much. They're actually more responsible for visual representation. So this is the inferior occipital gyrus. This is the fusiform gyrus. Essentially, these are just areas of the brain that recognize things like facial affect. And so what they would show these patients with these genetic variants, they would show them faces with negative valence, fear, anger, sadness. And what they found was that these patients with the genetic variants, whether it was the A, double A at the calcium channel, the T, the double T at the sodium channel, they saw increased levels of activity no matter which brain region they were looking at. In fact, the only place where they saw a decrease in excitatory activity was specifically in bipolar patients in their ventromedial prefrontal cortex. The authors aren't sure why, right? What that interaction is caused by, right? It seems to be some interaction with the diagnoses itself. But in general, these things lead to that increased amygdala activity, increased prefrontal cortical activity. And that data was replicated in 4 additional studies. You guys can see those studies down here at the bottom of my screen. More than willing, we're going to send this presentation out afterwards. They're all linked. And so you can definitely look into it if you're interested. The reason I bring these brain imaging studies up, though, is because, well, what can we do about increased neural excitatory activity? Well, we can consider medications that are neuroleptic, that may blunt this activity in the amygdala. right? And the reason I chose this study specifically with Pregabalin was that they used the exact same facial affective startle that they used in the previous slide that I just showed you guys. And what they saw was that the higher the dose of Pregabalin, right, the greater the reduction in excitatory signaling in the amygdala. You guys can see that in the top left. I've kind of highlighted it here in green. And so again, while we don't have any data showing that Pregabalin is more efficacious in patients with these calcium or sodium channel issues, right? We're looking at it from a mechanistic standpoint, and it's something you can certainly consider when evaluating your patient's diagnoses and treatment regimen. Now we're going to move on to the case vignette. Let's see. Oh, good. I've still got a little bit of time. And so we're going to talk about LF. LF is a 40-year-old white woman with generalized anxiety disorder and some mild depression. Her HAM-A was pretty high, actually. It was around 30, and her HAM-D was much more modest, around 12. And initially, she was trialed for about 16 weeks, so not a bad trial, of about 20 milligrams of escitalopram. She didn't really get any efficacy, right? There were actually some worsening of some of her somatic symptoms, like the stomach upset. And then afterwards, she was trialed on sertraline, 100 milligrams for about 4 weeks. In both cases, no real efficacy. So LF started attending weekly psychotherapy. She did see some minimal improvement in her HAM-A score. And that was followed by the addition of Venlafaxine about 6 weeks ago, right? That was titrated up to about 225 milligrams. During her follow-up appointment, her HAM-A had improved to about 18, her HAM-D to about 6, which is, obviously subclinical at that point. But she still complained of increased heart rate, stomach ache, muscle tension, and she reported less worry and rumination. So where do you go from here, right? What treatment would you recommend next for LF? I'm not going to spend too much time on this section because we already went over these gene variants and you guys are probably pretty familiar with them at this point. But just to cover them briefly, the SLC6A4 SS genotype is associated with a poorer response to SSRIs when it comes to treating major depressive disorder. Again, we don't know if that data is going to generalize to anxiety, but we do know that those patients also have an increased side effect risk. So maybe avoiding the SSRIs or at least moving past them, maybe it's not the worst idea. BDNF, right? We talked about this one before. Obviously, when we saw this, we wanted to talk to the patient about exercise and how that may improve some symptoms of her anxiety. But we did let her know, look, this was mostly studied in PTSD. We don't know if it's going to generalize to all aspects of your anxiety, but you are a much more robust responder. And then lastly, we kind of talked about some of that physiological dysfunction associated with that calcium channel. All those brain amygdala reactivity, the discussion we had earlier about, this increased startle, this increased amygdala level activity. And so we also talked about doing things that can maybe shut down that excitatory activity, things like Pregabalin. Also, we wanted to check her pharmacokinetics. Maybe the reason she failed her previous medications wasn't a lack of efficacy due to one of these pharmacodynamic gene variants. Maybe she metabolized the drug inappropriately. And we can see here that this patient was both a 2C19 and a CYP3A4 high activity metabolizer. What that means for her older treatments, right, the escitalopram and the sertraline, is that she's going to have decreased drug exposure, right? So lower overall dose, slightly shorter half-life in some cases. And so what these patients may have been experiencing when initially taking these drugs may not have been necessarily a failed medication trial or something that was inefficacious. It may have just been broken down too rapidly, right? The patient may have required a higher dose in order to see efficacy. We even see this same impact of metabolism on the Venlafaxine. And again, that may contribute to its partial efficacy. In fact, Venlafaxine, she actually has two mutations, the 2C19 and the 3A4, both increase the metabolism of Venlafaxine. And so that's going to additively decrease those serum levels. So what did we talk about? What did we do? Well, we discussed switching to a different SNRI, right? If the SSRIs are a problem due to side effects or inefficacy because of that SLC6A4 gene, then maybe let's try an SNRI, but one that isn't broken down quite as quickly as Venlafaxine. We talked about exercise, we talked about pregabalin augmentation, and we discussed some of the reasons why we were talking about pregabalin augmentation. Again, not because we have data showing that that drug will work better, but because this patient does unfortunately have some genetic predispositions for that increased startle response, that increased HPA-axis dysfunction. And so in the end, and just to draw it all together and to bring this back to Tori's section of the talk, there are multiple levels of this treatment algorithm that can be affected by your patient's pharmacogenetics, right? So I just want you guys to be aware that we're not even sure this patient had an adequate trial of an SSRI. She took escitalopram, she took sertraline. We can't even say she's fully fulfilled step 2 at all, right? And when she did switch to an SNRI, even that drug was broken down quickly. However, because she's failed these, she doesn't want to revisit those same treatment options again. We did discuss cross-tapering to duloxetine, which was not rapidly metabolized. And we also discussed the risks and the benefits of adding pregabalin if that duloxetine continues to not be able to control those symptoms of anxiety. For the patient, right, the patient was very happy with these results. Oh, I thought I just wasn't going to respond to anything. It's good to know I've been breaking these drugs down really rapidly. I was starting to not trust you guys. I didn't want to try another medication, but it looks like, well, maybe there's some hope. And that's basically the way that we want to talk about pharmacogenomics, right? It's one tool that can kind of help you move throughout that algorithm based on how your patient individually is going to either respond or metabolize those meds. Now it's time for the Q&A. I know I didn't leave us with a ton of extra time. It looks like we have about 6 minutes, but I'm going to end the talk on this slide, right? It's the same slide. If you guys attended last month's event with Dr. Patel and Dr. Williams, I thought it was a great slide to end on, and so I'm going to do so as well. And I'm just going to read off of it. As the field of psychiatry moves toward a biologically based science, as we learn more about the biological basis of psychiatric illness and their associated treatments, pharmacogenomics will continue to be an increasingly important additional tool for providers. Thank you. And if you have any questions, we'll now open it up.
Thanks, Russ. Thanks, Tori. I'll be the moderator of the questions and Q&A here. One of the very first questions we received when you guys started the presentation had to do with how these CYP450 enzymes change throughout the life cycle. So if you could stop sharing for 1 minute, Russ, I'd like to pull up a slide and maybe you can talk to it. I imagine you know what slide I'm going to share with you.
I do, absolutely. But if you have it right on hand, go for it.
Let me share it and you can speak probably more intelligently to this than I can. So take it away, Russ.
All right, let's go ahead and get into it. So yep, as Dr. Dowd mentioned, right, we have differing levels of these cytochrome P450s as we age. Most people are not aware that as an infant, right, we carry very little cytochrome 3A4. And people wonder, well, how do we metabolize those drugs? How do we get them out of our system? It turns out that infants actually express a lot more of what's called cytochrome 3A7. They break down many of the same substrates, but there are some minor differences. And so we want you to be aware of that, right? That's why we offer these clinical consults. We want to be able to talk to you about that. What's also really interesting is that there are some genes like 2C19 that are highly expressed early on and then eventually return to what are considered largely relatively normal levels by the time they reach adulthood, right? Right around the ages of 19 to 22, they tend to have what we call adult levels of CYP2C19. And so you guys can see that information displayed here, right? 2D6 comes up pretty quickly and then levels off into adulthood levels pretty early on. But the cytochrome 1A2 and the 2C19, those are expressed at a slightly higher level when you're young, and it is a more gradual return to baseline as you age. And so as you might imagine, right, if you're giving Lexapro or Celexa or Zoloft, those really, common medications that are given to children because we don't like moving on to those more, under-evaluated meds in the SNRI or other category of like Trintellixes and Vibrids and these types of drugs. We can see that, you can have massive changes in blood levels. Yeah, look at that yellow line that Dr. Dowd's kind of floating his cursor around there. Essentially, you can have a much higher or increased metabolism, right, of 2C19 substrates in those patients that are under, 16 years of age. And so that won't level out again until they're near adulthood. So, yep, can certainly impact pediatric dosing. And I guess, can we add this slide to the slide deck before we send it out? I think we can.
Sure. We'll just,
if you guys are interested in it, right? It's important to know that there are differences between individual populations, and so yep, that can be a good thing to emphasize.
One thing I'll add to that, Russ, 2C19 rapid and ultra rapid metabolism is one of the most common genotypes. Anywhere from 30 to 40% of the population is a fast metabolizer at 2C19. If you think of Zoloft, sertraline, one of the more common medications we give to children, their 2C19 status is at the highest it will be during their life. And and couple that with the fact that rapid metabolism and ultra rapid metabolism is extremely common, we may be underdosing a lot of these kids when we're considering sertraline. So something to keep in mind. And I'll go back to the Q&A here. I'm going to stop sharing, Russ, so you can pull back your slide deck if necessary. Another question would be, can you speak to how the algorithm may not be applied in a pediatric setting? Well, that's an easy one. Just use a pediatric algorithm and apply the same type of pharmacokinetic parameters or pharmacogenetic parameters to that pediatric algorithm.
Exactly, right. You're going to have obviously minor differences because some of these medications aren't approved for use, obviously, in those younger populations. But you're right. Choose your favorite algorithm, right? Your favorite pediatric dosing algorithm, and apply the results in a very similar manner. Yep.
Okay, so this looks like it has to do with SLC6A4, the short variant. Does the short variant suggest they should stay away from SSRIs, SNRIs, and the multimodal options like vilazodone and vortioxetine? So Russ, can you answer that question both for the short and the long short?
Absolutely. So what I would say is that if you have a single S allele, right, we do see an increase in side effects of there's a 50% increase in side effect rate. But if you look at a standard mild to moderate side effect rate for the SSRIs in a population of, let's say, 18 to 55 white women, right, it's generally around 12 to 16%. A 50% increase in that, and there are studies to support this, indicate that, that while that may rise to the level of that upper 20%, right, 26, 27%, that by no means guarantees that those patients are going to have side effects. That's why on the professional PGX test, we will not tell you to avoid the SSRIs. We will just say monitor for adverse events, right? That's the tagline for our report, because we do find that, an increased side effect rate that is not a guarantee. That is a increase in the probability of experiencing those. Now, as far as applying those results outside of the SSRI category, as you had mentioned, to things like vilazodone, vortioxetine, the SNRIs, unfortunately, the data doesn't support that, right? They've evaluated some of these other drugs, particularly the SNRIs, and they have not found, this increased side effect rate or this increased risk for poor response in these SNRIs. Outside of obviously the one study I talked about today for GAD and Venlafaxine. And so, I would say that, there probably isn't any need to avoid those medications, even though, yes, they share a similar mechanism of action, right? They do have some of that serotonin reuptake inhibition. They also have other mechanisms that may be more predominant in somebody who's missing, let's say, 50% of their serotonin transporters, right? Those other mechanisms of action may take over. That's one speculative way that these results may not apply to those other drugs. Now, having said that, the SS patients, right, people carrying 2 mutations, they are about 50% less likely to remit. They are about 70% less likely to respond. And so you'll notice on the professional PGX test, we do at least want you to consider assessing an alternative. We know treatment algorithms still want you to start at an SSRI, but at least with this data to back you up, you may have reason to move on from those drugs more quickly, right? That these patients are less likely to respond. They are less likely to remit. Again, it's not saying they won't, that they can't. It's saying they're less likely to. And so, yes, you may want to utilize those results and move forward in your treatment regimen or algorithm more quickly, knowing that those SSRIs may not have as good of a response rate. Hopefully that was clear.
So I think the quick summary there is short homozygotes, poor response and poor tolerability. Heterozygotes, long, short heterozygotes, doesn't really impact response or remission, but does seem to impact side effect rates. Okay, so for either Dr. Hoffman or Dr. Amato here, a question about, this looks like a specific question about paroxetine and venlafaxine, and whether the expression of these different genetic enzymes can explain suicidal thinking related to the antidepressants. Specifically, those two were called out, paroxetine and venlafaxine. I'm not sure. I mean, I'll chime in here. I'm not sure we can extrapolate and say because you're a poor metabolizer of one of these medications that increases suicidal thinking. Paroxetine is one of the medications that is extremely sensitive to 2D6 metabolism. About 1/3 of the world is considered an intermediate metabolizer of 2D6. About 6% of us are considered poor metabolizers. The same would be true with venlafaxine and 2D6. So there's a big chunk of the world who don't metabolize those drugs cleanly. They would be likely to experience more side effects. I'm not sure we can extrapolate that and say that's the cause of suicidal thinking, though.
Yeah.
Agree. I have seen a couple studies looking, one of the genes we didn't get to talk about today, but something that some of these antidepressants do have in common, and I have seen some literature looking into it, is the potential influence of P-glycoprotein and ABCB1 variants on something similar. There's not a lot of evidence. Like I said, it's very early, but that might be something to, I could send you a follow-up if you're interested on what I have seen, because I have seen a couple of them, but not anywhere near enough to make any hypotheses about an association.
Thanks, Tori. We have another question here. The slideshow, or that slide that we showed regarding enzyme activity in children, can we explain the differences between Prozac and Zoloft? So this is probably a reference to 2C19, but Russ, can you just describe the different pathways of Prozac and Zoloft?
Absolutely.
You can go back to the slide where I have them listed.
Oh, yes.
Yep. And so what's going to be important here, let's see, I'm going to go, actually, you know what, let me get out of
that
presentation.
Works too, actually.
I'm going to get out of present. Yeah, it's true. That does work. But I'll go back to your slide because it's more informative. And so as far as those two drugs, right, we're going to go ahead and increase the size again here. When you look at fluoxetine and sertraline, obviously sertraline is the 2C19 substrate. That's the enzyme that's expressed at higher levels, right, during early childhood into adolescence. And so, yes, these patients may break down sertraline more quickly, but, and this is important to distinguish, some drugs are predominantly metabolized by an enzyme like 2C19. These are drugs like escitalopram and citalopram. And then there are drugs which they're secondarily metabolized, right? Not as much of the drug is broken down, maybe only 20 to 30%. And so we wouldn't expect for any changes in 2C19 to have as great of an impact on sertraline levels, right? Because it's a secondary pathway for 2C19, as it would on something like an escitalopram or a citalopram. And the way that you get that information, right? Again, it's very hard to tell that looking at Tori's slide, right? There's nothing to clue you in that 2C19 is a primary pathway for Celexa and Lexapro, but it's not for sertraline. But that's why we developed that software tool that Dr. Hoffman talked about earlier. If you go into that GenMed Pro tool and you look at a 2C19 rapid or ultra rapid metabolizer, you're going to see a much stronger impact on drug exposure for those major primary 2C19 pathways, right? Like Lexapro, like Celexa, and you're going to see a much more modest impact on drugs like sertraline. I hope that was clear. As far as the fluoxetine, there aren't too many changes in levels of 2C9 and 2D6, at least not really in the age ranges where you're using fluoxetine. And so I don't know if that data will be as valuable for the Prozac specifically.
Yeah, I imagine this was a question, focusing on the
more on the sertraline.
Pediatric SSRIs. Every SSRI has a CPIC guideline associated with it, with the exception of Prozac. So there are dosing recommendations that CPIC recommends for citalopram, sertraline, and escitalopram based on your 2C19 genotype. There are dosing recommendations for Luvox and Paxil based on your 2D6 genotype. There are currently no dosing recommendations for Prozac, regardless of what your 2D6 genotype is. So you need to be more concerned with sertraline and genetic variability, at least drug metabolism variability, than you need to with Prozac. The bigger red flag with Prozac is that it is a strong inhibitor of 2D6. So there's far more drug-drug interactions with Prozac. Okay, we're coming up against the hour here. We're actually a little past the hour. So we'll take maybe one or two more questions and then we'll start wrapping things up. Is there a reason that we mentioned pregabalin as opposed to gabapentin?
Yes. And so the reason we mentioned pregabalin is, well, first off, right, that was the one cited in the actual Harvard South Shore algorithm that we were discussing today. And the reason that that drug is present in that algorithm is because it's been studied in placebo-controlled trials for generalized anxiety disorder, where that data doesn't exist for gabapentin. And so this drives home a very, very important point, right? And that point is, just like Dr. Hoffman pointed out in the beginning, pharmacogenomics isn't the only tool that you guys can utilize to help, choose these medications. We also have to look at the literature, right? We need to look at the pharmacology, and we need to be aware that, if there's better data for a drug in treating a certain diagnosis, that we should probably lead with that drug that has better data, regardless of what the genetics are telling us, right? We need to take that into consideration and kind of merge that information and not only try and choose something that's safest and maybe most compatible with their genetics, but also has a pretty good track record for, actually treating the disorder we're talking about. Yep.
Okay, thanks, Russ.
In the guidelines from Harvard South Shore, they do actually discuss this, and they say that despite the lack of evidence for its efficacy in regards to gabapentin, that, it could be a possibility to consider if pregabalin is too expensive or there's, formulary restrictions, things like that. But ultimately, exactly what Russell said, that, for pregabalin, there's been some really compelling evidence, but unfortunately, for some reason, gabapentin's just hasn't shown that.
Well, I think this is a good place to stop here. This presentation has been recorded. It will be posted. You'll receive a copy of this via email tomorrow. One of the things I would ask everyone to do, in the email, you will receive a link to an evaluation for your two presenters tonight. So Dr. Russell Amato, Dr. Tori Hoffman. These evaluations literally take 1 minute. So if you could take the time and provide some feedback on your two speakers, we would appreciate that. We're trying to always improve our process here. So we'll send that out tomorrow. Before I wrap things up, Laura, is there anything you want to say to the audience here?
Thank you for your time tonight. I hope you found this valuable. I thought the Q&A was really robust and interesting, and we saw a lot of comments that it was very thorough and well presented. So thank you both to Dr. Amato and Hoffman, and of course yourself, Dr. Dowd.
Okay, thanks everyone for their attention tonight. Hope to speak to everyone soon and have a great evening. Thank you.
Thank you.
Good night.
Night.